Hello, my name is Carol Navarez, and I am presenting today on the complications in teen pregnancy due to the lack of prenatal care by multiple young ladies in this age group. My Peacock question or statement is that in teen age and young mothers age 13 to 21, does the initiation of prenatal care during the first trimester compared to beginning prenatal care in the third trimester reduce the incidence of emergent cesarean sections during labor and delivery? The problem with teen pregnancy has been an issue for a long time for healthcare providers and parents. According to Lopez et al. Of 2020, one of the big issues is that the healthcare provider must be able to see the infant as a separate patient of as the mother. We do have evidence-based practices in place keeping both the patients safe during pregnancy and delivery. The problem is we can't always get these young girls into care because they're scared to tell their parents, or they don't even realize that they're pregnant. Some of the issues and outcomes that we have due to the lack of prenatal care is that if prenatal care is not initiated until after week 20, the Department of Health and Human Services in Texas has multiple reports that these infants, especially those of Hispanic, Black, and Asian mothers, have a higher incidence of infant mortality. These infants have low birth weight and they have a failure to thrive diagnosis. And oftentimes these mothers are readmitted to the hospital after discharge, which causes complications for the baby also because the baby is at home alone. We also see nationally that there is a higher rate of maternal death in Black women of non-Hispanic backgrounds, according to the American College of Gynecology. On the other hand, when we have these moms who come in and initiate prenatal care before week 20, we do have a lower rate of emergency cesarean sections, which gives them a shorter hospital stay. They have less chance of post-delivery infections, and they have healthier infants due to the education they received during the prenatal care. As I was researching my subject, I found that Sharkley in 2020 found that teen mothers who received consistent prenatal care beginning in their first trimester had a noticeable decline in anemia, hypertensive disorders, and low birth weight infants. We also saw that Kern Goldenberg et al. In 2025, 3 years later, emphasized that this early engagement prenatal care gave maternal health literacy to these moms so they were able to make better informed decisions. Because when you have a mother who is not as mature as an adult mother, and they're making their own decisions about nutrition, about whether they're going to go to a follow-up appointment, whether they're going to breastfeed, or they're going to engage in any risky behaviors like drugs and alcohol, or even smoking cigarettes. If they're in prenatal care, they're more likely to make better choices. The Texas Department of Health and the World Health Organization in 2024 showed that delayed care correlates highly with a higher incidence of cesarean delivery, preterm births, and the need for neonatal intensive care admissions. So therefore, by the synthesis of this evidence from the quantitative studies and the systematic reviews all revealed that there's an agreement that early prenatal care intervention is preventative for problems, and it's educational for the mother for a high-risk teen population. When performing the search strategy and the results, it was difficult to narrow down some of the criteria needed for this specific research question. Data was collected from multiple sites, and I used that data and determined based on the age of the study, the age of the participants, and where the particular study was focused on, whether it was in the United States or if it was in Ethiopia or India, on whether this criteria would be used in the information collected for my research project. The main words I started with were teen mom, teen mother, birth mother, prenatal care. And then I started to include words like unplanned pregnancy, adequate prenatal care. There was multiple databases that focused just on complications, and so I was able to find some of that information by using Google Scholar, which Google Scholar is also who led me to the CDC, the American College of Gynecology, or ACOG, and the Department of Health had multiple studies that talked about birth mothers and the vital statistics that they have found for teen births and teen deaths and complications. Changes that need to occur, and I think the Lewin's change model is the best change model that I can find. It's has the least steps, because there's so many people that are going to have to be involved in this change. When I looked at the American College of Gynecology's evidence from 2021, that showed that the evidence-based practice of initiating prenatal care for teen moms during the first trimester is a level A on the Johns Hopkins quality rating scale. And there is multiple studies, multiple proven theories that have shown over decades, even though we're constantly improving on how we provide care, a lot of the older information still rings true. We need these mothers in care early to reduce the risk of preterm births, low birth weight infants, and maternal complications such as hypertension. We also don't think about teen moms having diabetes, but their bodies are so immature. We don't just see gestational diabetes in older mothers anymore. We see it quite often in these young moms whose bodies are not really adapt and ready to carry a pregnancy to term. So we need to make a change of ensuring at least 10 prenatal visits before delivery for all teen mothers. We need to make sure that this group of children, this group of mothers, knows how important prenatal care is, because it's lacking in all states, not just in the Southwest United States. We can provide education at schools and at after-school programs for these teen mothers, because we can begin seeing these mothers as soon as possible. We need to work together as healthcare providers and focus on Medicare coverage, not just beginning, but knowing when we can file for these charges, so that if the mom has to be seen at her first appointment free of charge, or be seen at a free clinic and then transferred to a gynecologist's office, something has to be done to enable these moms to receive care sooner than later. The criteria needs to be when or what trimester did this birth mom, this teenage birth mom, begin prenatal care, but also how old she was at conception. And if we look at conception, then we need to look at delivery, because we sometimes will have a mother come in that's 13, but she got pregnant at 12. We also need to look at the mother's race to see if there's going to be a area that we need to really focus on and test for and make sure this mother is okay. We also need to be cognizant of the income level of the family. If the family is very low income and they don't have access to transportation, there's not civic transportation in the rural areas where they live, how are we going to get that teen mom to her appointments? Does she need to have care provided by telemed? So for the data collection and analysis, it needs to begin at the first visit by the OBGYN. We also need this mother to be able to provide information. We need information about the EGA of the pregnancy. This is sometimes easier done by mobile intake forms or emails where it's computerized. Sometimes we can get income data collected during a Medicaid appointment if we're assisting that mother or that family in applying for Medicaid so that this teen can have medical coverage. This is the only way, by collecting all the information and having it in written form of some kind, whether it's handwritten or it's voice documented face-to-face by the practitioner or the nurse at that first visit, or it's done on the phone prior to them coming in, that we'll be able to evaluate what needs to be done and how the changes are affecting these patients. The dissemination of this change is incredibly important. Information needs to be shown in statistical format, whether that is just written statistics, handouts, a presentation on a blackboard, a presentation over a YouTube format. However we can get that information to the institutional level, we need to have local hospital CEOs, OBGYN offices, WIC office employees, nurse managers from the OB floor, any nurses that she has down as charge nurses to evaluate the criteria. It's going to take teamwork. So we're going to have all these team members trained and be able to read and review the collective mobile forms and the OBGYN assessments. The criteria has to be monitored. We need to know when the care began, the age of the mother it began at, the EGA at birth, the number of prenatal appointments she attended, the birth weight of the infant, post-delivery complications of the mother or of the infant. Did that infant require NICU care? So the tools we need for this are not just those mobile forms and hospital records and birth records. We need the records and the memories of all of these team members who are providing care for these clients to be on the same page. So dissemination of that information is highly important. They need to understand why it's needed and how we're going to put these changes into effect so that it becomes the normal everyday care for teen mothers. So the conclusion that really shows with all the information after this information has been reviewed and synthesized is that prenatal care needs to start as soon as possible, as soon as the pregnancy is confirmed. ACOG recommends starting prenatal care by week 8 and seeing that mother every month until week 28, and then every other week, and then every week starting at 36 weeks. There's multiple tests and multiple procedures that need to be performed during that time. A mother is going to miss appointments, especially if she's a teen mother that does not have transportation. So the more appointments we can get her to beginning early, the better foundation we have to start a healthy outcome for that mother and that infant. So early intervention improves maternal and income outcomes, but also the social benefits, because we have healthier generations to come and reduced healthcare burdens, according to Olds et al. of 2019. To effectively implement these community-based outreach programs, we have to have these teen mothers be aware that if they are on Medicaid, there is Medicaid-funded transportation. We have to make information available to not just the mother, but to their parents that's culturally competent, that's in their language, so we can get these parents to understand why it's important that these children are seen and how to get them the help that they need. By having nurses provide health care and home visits, we can improve the mother's outcome and the child's outcome, but we can also provide some of that prenatal care that is missed in the first months and that prenatal education that helps these mothers learn and make better choices so that they can continue to have a healthier pregnancy and carry to full term. Thank you for listening to my presentation. I hope you found it educational. My references are on the following slides.